This presentation today is about qualitative interpretation of OCT macular, and this is part 1 where we'll just get familiarized with the OCT and the relevant anatomy as depicted by the OCT. So I'm not dealing with the physical principles of OCT and the generations of OCT, but we'll just focus on what the posterior pole retina looks like on an OCT. My target audience is my postgraduate students and general ophthalmologists who are not well versed with the OCT, and the objectives are to understand the normal OCT in comparison to retinal histology, as we have already studied in our first year MBBS, and identifying the individual retinal layers as seen on normal OCT. And the second part will deal with the identification of the abnormal features in an OCT and correlate the abnormal findings to common retinal diseases. So this is just a pre-assessment, just to see if one really needs to go through this lecture. So my question is whether we can easily identify these hyperreflective layers. So here we can see there are 1, 2, 3 hyperreflective layers here, and one very faint hyperreflective layer which is seen here. It is more prominent in this area, and all these 4 layers, can they be identified by the student? Second question for this diagram is, which eye is this? Is it the right eye or is it the left eye? Can you decide by looking at this OCT image if it has not been flipped? So this is something which can be judged right now and can be used as an index when finally finishes off this series of 2 lectures. I'll show you a few more images just to have an assessment, and this will deal with the disease part as seen on OCT. So here we have 2 similar images in which we can see this part of the image, their layers are split, and same goes on to here where there are multiple such disturbances. Now can you differentiate between these 2 lesions? Then we have one more image here where we have very similar kind of picture where there's a split between the images and there is a collection of clear and amorphous reflectivity in between the layers. And here we have another OCT image where we have distortion of this particular layer along with collection of some amorphous and reflective materials up underneath this. Coming to the final pre-assessment image, we have 2 images here. We can see the retina in this portion has lost its foveal depression. Instead, we have thickened retina here with cystic clear spaces and some amount of space which is clear in this area. And on this image, we have a distortion in the baseline portion of the image, some cystic changes here, and overall a thickened retinal image. Now one can judge by looking at these images how much information you have, and you can again come back and assess whether you have answers to these once you have gone through all these slides. Now let's define what is posterior pole and OCT macula is what it is about. So we are here where we can see the OCT corresponds to a 6 millimeter width of posterior pole centered at the fovea, which is represented here in this schematic diagram here, and this area will cover nearly about 5.5 millimeter or this much area. So a OCT provides you an image which gives you the detail of this particular area. This will vary because depending on the optics of the eye and the refractive status of the person, the magnification or minification may occur, which can cause some changes. A list of OCT macular terminology. Here we will just introduce these terms, which we'll keep on learning as the slides proceed. So we have retinal pigment epithelium. This is one of the layers of normal retina, which we already know, and this is visualized on OCT. Then we have ellipsoid zone, which is the junction of the inner segment and outer segment of the photoreceptor layer. And then we have pathological condition where you have subretinal fluid. This is retina between the neurosensory retina and the retinal pigment epithelium. And we have pigment epithelial detachment, which again is a pathological condition. Thinning of retina is also known as atrophy, so this is a term. Subretinal hyperreflective material, which can be amorphous and which can be compact. Fluid, when it is present in the neurosensory retina itself, it is known as intraretinal fluid. It can have a clear space, it can be speckled, and it can have a diffuse thickening. Inner retinal opacification is another pathological condition. Hyperreflective foci, outer retinal tubulations, posterior cortical vitreous is a normal term which we will see as a distinct layer in few OCTs. Epiretinal membrane is a pathological condition. Lamellar macular hole is a pathological condition, and full thickness macular hole is also a pathological condition. VMT and VMA, that is vitreomacular adhesion and vitreomacular traction, are again pathological conditions, and so is the macular schisis. And all these conditions we will see as we proceed. Now this is one slide which I had created with lot of intent, and I want all my students and audience to pay attention to this particular slide. It has so much information to learn. Now I had divided these layers into bands and zones. Now these are distinct layers which are seen on OCT, but the difference is that bands are those structures which are discrete on OCT and they have a histological relevance. Zones are layers which are not having distinct boundaries and they don't have a histological counterpart. And I have labeled the bands as these kind of arrows which are changing colors and zones as just black arrows. So keep in mind when we proceed, each one of the layer will be represented by this particular kind of arrow. And this is one histological image which can represent, although it's slightly schematic, but it can represent a histology of the retina. And here we have a corresponding OCT image. So you'll just see histologically the structures which correspond to the layers seen on OCT macula. Now this is the outermost layer which is most reflective in the neurosensory and retinal pigment epithelium, and we have also labeled these gross layers as choroid here, and then we have retina which extends from this portion to this portion, and this is choroid, and outer to this we'll have sclera, and this portion which is clear is vitreous. So what we are going to study is this structure extending from this inner aspect to up to this outer aspect. So let's proceed now. Now, the first layer which is to be identified when reading OCT is retinal pigment epithelium. So this layer cannot be distinguished separately because it is fused with the Bruch's membrane. So basically it's a retinal pigment epithelium and a Bruch's complex. So this is one of the most hyperreflective layers as seen on a macular OCT. Then we have the interdigitation zone. This is something which is basically a connecting layer between the photoreceptor layer and the retinal pigment epithelium, and that is why it is known as interdigitation zone. Here we have fine digits or projections of the retinal pigment epithelium which engulf the photoreceptor's outer segment. Then as we proceed inward, we have the outer segment of the photoreceptors, which is seen as a hyporeflective zone. And then we have the ellipsoid zone, which is basically a segment between the outer segment of the photoreceptor and the inner segment of the photoreceptor. It is seen as a hyperreflective zone on a OCT. And this is the inner segment which is seen bisected by the ellipsoid zone, and here we can make out that this central hyperreflective line is the ellipsoid zone or the inner segment outer segment junction, and on both the sides we have the outer segment and we have the inner segment of the photoreceptor. And as we proceed inward, the next layer which we encounter is the external limiting membrane, and this is slightly faint but hyperreflective when compared to surrounding layers, but it is fainter when seen when compared to the ellipsoid zone or the retinal pigment epithelium. Now these are the four layers which I had talked to you about the pre-evaluation slide, and now I think you can make it out on these OCT scans. Then we have layers which are thicker and much widely placed. The next layer comes out to be is the outer nuclear layer, which is hyporeflective. It is less dense. And next is the outer plexiform layer, which is basically the junction between the outer nuclear and inner nuclear layers. And then we have the inner nuclear layer. Then comes the inner plexiform layer. And then we have the ganglion cell layer. And then comes the nerve fiber layer, which is usually seen as a layer which is more defined on the nasal aspect, which is closer to the disc. And this portion is which is further away or temporal to the fovea has a nerve fiber layer which is thinner and less defined. So any eye where you see that this nerve fiber layer is thicker means this is closer to the optic disc. Revising the same content again, OCT Macula Nomenclature, we can again revise the same issues. We have Bruch's membrane, which is seen as fused with the retinal pigment epithelium here. Then we have the photoreceptor integrity line, which will consist of ellipsoid zone, inner segment, outer segment junction, and outer to that we have a hyporeflective interdigitation zone where the photoreceptors are interdigitating with the retinal pigment epithelium. So this is basically a hyperreflective area. And then we have the outer segment ellipsoid zone, the inner segment, which inner segment and outer segment are hyporeflective, and the ellipsoid zone is hyperreflective. Then we come to the external limiting membrane. When we look at the layers which are inner to all these structures, which are widely spaced, we find we have outer nuclear layer, which is hyporeflective, outer plexiform layer, and then we have inner nuclear layer, inner plexiform layer, ganglion cell layer, and nerve fiber layer, which is fused with the internal limiting membrane. Now, I think this is enough for revising now, and I wish that the audience can take a break just now and take some time to revise all this. Thank you. So welcome back after that break. And now we'll embark upon the retinal diseases which can be seen and interpreted on OCT. And how do they look on a OCT? Now here we have an image, a fundus photograph, which is showing a lesion. If you can make out, here is one translucent elevation in the retina, which I can make a border of that. And this appears like a solid elevation. Similarly, there's a small elevation in this area also. And these are pigment epithelial detachments, which can be seen on direct ophthalmoscope as a translucent, transilluminating elevations of the retinal pigment epithelium. And on angiography, these can be seen as a hyperfluorescent area which fill up after a while, and they are confined to a very limited space with discrete boundaries, and this is what is known as pooling. So these are usually associated with central serous retinopathy also, and when we look at them on a OCT, this is what we find. So if we start tracing our retinal pigment epithelium, so we'll find that Brooks membrane and retinal pigment epithelium, which are fused, we start tracing that, we find the Brooks membrane and the pigment epithelium, they separate out, and we have a cystic and a round elevation with a clear cystic space between the layers here. And this is what a pigment epithelial detachment will look like. And this is more convex when compared to central serous retinopathy, for the reason that the retinal pigment epithelium is much more tightly adherent to the underlying basement Brooks membrane. So when the fluid starts collecting in this space, it becomes difficult for the fluid to dissect these two layers, and so hence the pressure inside this cyst has to elevate to a higher value, then only it can cause a lateral dissection. So in this process, the pressure rises in this cyst, and so there is higher elevation compared to a lateral dissection of the tissue. So the pigment epithelial detachments are always more tall when compared to central serous retinopathies. Now this is one photograph which is showing us some amount of pigmentary disturbances and presence of drusins. So you can see these discrete deposits in the subretinal space which are close to the macula, and we have some amount of pigmentary changes at the fovea and macula itself. When we do angiography, we find that they take up the stain. So this is when the fluorescein dye is sticking to a solid lesion on the retina. This is the term used as stain, and how does it behave on angiography is that there will be a initial hypofluorescence, hypo, and then followed by a hyperfluorescence, which will persist over time but not increase in size, and gradually in recirculation phase it will start fading out. When we look at a corresponding OCT, and if we start tracing, because these are subretinal deposits, rather sub-RP deposits, so you'll find that when we start tracing the RP and Brooks membrane layer, it starts getting irregular at these points where the drusen's are present. Similarly, it gets irregular here when you have a drusen, and this keeps on every section wherever it passes through a drusen. So this is not a clear space if you look at the underlying space here, and as compared to a pigment epithelial detachment, these spaces are reflective, indicating that there is some material present there. Coming to age-related macular degeneration, which is of wet type, and here we'll see subretinal hyperreflective material, which will be basically a fibrotic tissue. It may be serous fluid, it may be a bleed, a hemorrhage. When we look at the angiography, we can see obvious SRNVM here, which is type 2 membrane, which is visible to us on angiography, fluorescein angiography itself. And we start looking at the OCT, we'll find that not only that the retinal pigment epithelial layer is disturbed, we have a hyperreflective space occupying lesion here in this space, which is between the retinal pigment epithelium and neurosensory retina. So this subretinal neovascular membrane has broken through the retinal pigment epithelium and is lying in the subretinal space now. We can also appreciate some amount of cystic changes here, and there's a large cyst here which is basically present in the retina and may mimic subretinal fluid, but here we can make out that the layers of retina are present in this area, so indicating this is an intraretinal cystic space. So this is what a subretinal hyperreflective material will look like on a OCT, as seen in a wet AMD. Coming to branch retinal vein occlusion, in these lesions, we have venous circulation in one of the quadrants of a major tributary of the retinal vein is obstructed, and hence because of the back pressure, the capillaries, they burst open and there is collection of blood in the retina. So this is basically retinal hemorrhage, and because it is in the retinal layers, so it confines to the direction or the pattern the retinal nerve fiber layer has, and that is why these are flame-shaped hemorrhages. Here we can see that some time has elapsed, so the flame-shaped hemorrhages have started decomposing, and now they are more like dot blot hemorrhages. When we look at the OCT, we'll find the circulation part which is affected to a greater extent is thickened here in this area. This is the foveal area, and this area is not affected, which we can make out this is the right eye, because this portion is thicker nerve fiber layer close to the optic disc. This is the temporal part, this is the nasal part, this is the right eye. And we can see not only that the retina is thickened in this area, but there is also cystic space in the retina, which indicate retinal edema. And also there is some amount of subretinal fluid here with some deposit in the subretinal space. So this is what a branch retinal vein occlusion will look like, where you have half of the retina which is normal and the other half, which is effective, has edema. What happens in a central retinal vein occlusion? Although this is not a very severe central retinal vein occlusion, rather if we can classify it, it becomes a non-ischemic variety because there's lack of hemorrhages in all the quadrants, and the hemorrhages are not that dark and widespread, but nevertheless it has affected both the portion of the circulation, the upper half and the lower half both. In these cases, again, because there's a hampering in the venous return, so capillaries, they burst open and you have retinal hemorrhages, which initially would be flame shaped and later on it will develop into a dot blot hemorrhage. And when we look at OCT, we'll find that the OCT will basically represent, so we can see this is the right eye, a thicker nerve fiber layer in this portion, which is the nasal part. This is the temporal part, and we can see cystic spaces with some amount of subretinal space filled by a clear fluid. And although what we can make out that the retinal pigment epithelium here is grossly intact, and the overlying photoreceptor layer and the ellipsoid zone is disturbed with presence of fluid in this layer. And we have cystic spaces which indicate retinal edema. So here we can make out that both the portion around the fovea are edematous. And this is because the global circulation is affected, so there is no such division as seen on a branch retinal vein occlusion. This is one picture where we can see that the central retinal vein occlusion is in a resolving phase, and the flame-shaped hemorrhages have condensed into dot blot hemorrhages, and we can also make out that there is optic atrophy, indicating that irreversible damage to the nerve fiber layer has occurred. On angiography, this is what the picture is like, and you will usually have a delayed filling of the veins indicating poor return, and there's masking because of the retinal hemorrhages, and as the time will progress we'll see presence of macular edema. And on a OCT, if you look at, we can see the retina has thinned out, and we can also make out that this is the left eye looking at the nerve fiber layer, which is thicker here and thinner in this area, and we can make out that the retina is thinned out, it is atrophic, which corresponds to the finding that there is optic atrophy. There's hardly any edema now, and this also indicates that those medicines which are used like steroid and anti-VEGF are not going to help here, because these medicines can only resolve edema and they don't help when there's tissue atrophy or lack of blood circulation. Now, when we look at few other lesions which are commonly seen in other diseases, these are hard exudates, and when we look at a OCT, we'll find that these hard exudates are present in the nuclear layers, and here we can see the outer nuclear layer is filled with this hard exudate on a cross section, which is seen here on a front and face photograph. And if we can make out not only that it is present in the outer nuclear layer, it also casts a shadow. Now this is typical of a hard exudate because this tissue is very reflective, and as a result the signal which is coming, the light rays which are coming from front are blocked, and because there's lack of light energy in this portion, so there's no reflection going back. So as a result you have a shadow, just like in a normal day-to-day life when we have an opaque object in front of a light source, it casts a shadow, and same thing is going to happen here. So if just to erase my markings, and I would like you to appreciate that there's a distinct area which is corresponding to the opacity in this outer nuclear layer, which is casting a shadow here. Now, this is a sign of hard exudates, and when compared to drusen, these hard exudates are more in the inner layer, and the drusens would be more in the retinal pigment epithelium side, as seen on OCT. Now, subretinal neovascular membranes can be because of age-related macular degeneration and also because of inflammation. Now, here we can see a patient in whom there we have an inflammatory SRNVM, which is basically a toxoplasmosis causing inflammatory SRNVM at the fovea itself, and we can make out that the retinal pigment epithelium, we start tracing it from the normal side, will find that it gets disturbed and elevated in this portion, indicating presence of lesion which is occupying some space in this area. And because this is not clear, this space is not clear, so indicates there's a presence of solid tissue or an opaque fluid. Correspondingly, we can also make out that the inner layers of the retina are thickened, and we don't have a foveal depression here, and we also have cystic spaces. All these things indicate inflammatory SRNVM, which is seen in younger age group and is usually unilateral, and there will be absence of drusens here. Subretinal hematoma as can occur after trauma. So this is one child who sustained injury by a ball, and we can make out in this portion is slightly elevated, and we can see a slight discoloration of slightly greenish hue, which comes when you have subretinal blood which is collected here. We can also make out some corrugations in the retinal tissue because of distortion of the tissue as caused by this hematoma. And we can make out that when we do our OCT, we find the retina tissue is nearly normal. We have a foveal dip also. We have few cystic spaces. And then we have retinal pigment epithelium, which is grossly elevated in this area. And then we don't see anything because this is filled by blood and there is no signal which is able to pass through this opaque blood. So we have a shadow here. When this patient was treated by using anti-VEGF and a gas bubble placed and the patient maintaining a face down position for a while, this is what we have now finally. That there's a scar here and there's a scar in the retinal pigment epithelium, which is filled by a scar tissue which is grown from the choroid, and this is the cross section we can see. So this is basically a scar in the retinal pigment epithelium which is causing some elevation here, but we can also make out the blood has resolved and there's no tissue edema except for a small cystic space here, which I don't consider is edematous. It's basically some kind of retinal degeneration. Now this is inner retinal thickening, which is a sign of ischemia, a gross hypoxia in the retinal tissue. So this is inner retinal thickening, which is seen in ischemic conditions. Here we have a patient with central retinal artery obstruction, and if you look at this image, we have cherry red spot here, which is basically an area where the retina is grossly thinned out. So we have visibility of the retinal pigment epithelium and choroid circulation. And when this is compared to rest of the retina, it appears edematous and opaque and white. So this area is highlighted in form of a red spot, which is known as cherry red spot. Although The abnormality lies in this particular area, which is ischemic, hypoxic, and opaque. And when we do a OCT, we'll find that these retinal layers, the inner side, have become thickened and opaque. And they no longer allow visualization of underlying layers. So this is inner retinal thickening. The inside portion or inner layers of the retina are thickened and edematous, opaque, secondary to a central retinal artery obstruction. Now this is a picture of a macular hole and a corresponding OCT image. So on a fundus photograph, we have a defect in the neurosensory retina at the fovea, and we can see retinal pigment epithelium through this. And when we start looking at the OCT, we find that fovea is disrupted and the tissues have been pulled back due to tangential forces, and we have a split here which causes a full thickness defect, and these are the two edges of the retina which have separated out because of this tangential force. And we can also make out few cystic spaces in the inner nuclear layer which correspond to some amount of edema in the tissue, which is commonly seen in these macular holes. Although this edema is more pronounced in the edge of the hole, but here we can see it spread out over a larger area. So this is what a macular hole will look like on an OCT. Central serous retinopathy. So central serous retinopathy can be and has to be distinguished from the ARMD and pigment epithelial detachments. And as I had mentioned earlier, central serous retinopathy and pigment epithelial detachment have a very characteristic difference. Here if we can make out the retinal pigment epithelium is continuous, it is not disturbed at all. And then you have neurosensory retina which is separated out, and we have a clear cystic space which is definitely more shallow when compared to pigment epithelial detachment. And this is again because the fluid collection in this space has a easy spreadability because the adhesion between these two interfaces is much less when compared to the Brooks membrane and retinal pigment epithelium. So when you have a PED, it will be more localized and convex like this. And when we have CSR, it will be more shallow and spread out the way this is. So this is one characteristic difference between central serous retinopathy and pigment epithelial detachment, although these two conditions can coexist in one patient. Commonly seen as a pigment epithelial detachment, which is much smaller in size and lies within this area of serous detachment of central serous retinopathy. Now this is one interesting photograph where the PVD has occurred, and we can make out that there is a posterior cortical vitreous which is present in this area, and this is the anterior limit of the cortical vitreous. And this can actually give rise to various pathologies like ERM and macular hole pucker, macular hole, and at times it is necessary to remove these membranes so as to cause relief of the tangential traction which they can cause. So if you have a cortical vitreous adhering to the posterior pole, it can give rise to epiretinal membrane. And here we have that situation. We can see the epiretinal membrane attached as a sharp hyperreflective line which is attached on the retinal surface at posterior pole, and at places it is slightly detached from the underlying neurosensory retinal surface, and wherever there is adhered, it has pulled the retina up. So here we, instead of having a foveal dip, which correspond to something like this, we have elevated fovea, which is because of the pull and distortion caused by the epiretinal membrane. So this is what epiretinal membrane will look like, as a distinct membrane overlaying the surface of the retina and causing distortion. And this distortion is a sign that this patient needs intervention, because this will contribute to diminution of vision and distortion of vision. Vitreomacular adhesions. Now, one thing which I want to point out first out at this image is that this OCT appears so curved, and this is because this patient is highly myopic. So correspondingly, when you do a OCT in these patients, you will find that the OCT image will not appear flat, it will appear curved. And here we have adhesion of a fibrotic membrane here, which is although not causing much distortion, but there's an adherent membrane here, which is adhered to a membrane in the vitreous as well. So this may cause distortion of the retina later on, although at this moment it is not contributing much to distortion of the retina. And retina is thin also, as you can see. This is a myopic patient, and myopes have a thin retina at posterior pole. When these tractions or these adhesions, they start pulling the retina up, they start distorting the retina and causing either tissue edema or separation of the layers. So here we have vitreomacular traction. Here we can see this is the point of junction between this traction, and this looks like the flagella of the cockroach. So there will be always two ends of this membrane which are causing the pull, and the portion which is attached at the retina will be elevated in a tent-like fashion. And this distortion, when it is pulling the retina up, there will be spaces in the retina causing tissue edema, which is passive, and also splitting of the retina. So this is a condition which will require a careful membrane removal and an ILM peel, although ILM peel will not be very safe for this condition, because this can actually cause increase in the split of the tissue. This is one condition which we can see. This is a case of branch retinal vein occlusion. This is a case of age-related macular degeneration, as we can make out that there is a distortion in the retinal pigment epithelium, and there's an amorphous collection of subretinal tissue, and there's a clear SRF with some deposits here and cystic changes in this retinal area. And what I want you to understand and notice is that you have outer retinal tubulations, which are these structures which have a cystic clear space and a hyperreflective cystic wall. And these are indication of a end stage degeneration of retinal photoreceptors and indicate a poor prognosis. So this is a cystic space, but this is outer retinal tubulation. So this is one of the very nice and interesting OCT and a fundus photo which received an award, and this shows us a myopic macular schisis, which is commonly seen because of a taut retinal surface, a rigid retinal surface, and a hyper curved posterior surface. So there's a relative traction between those two surfaces, as this surface is very tight and rigid, and this surface is curved. So it can cause macular schisis, as you can see here. So now coming back to our starting point and reassessing if we can judge these images correctly now after going through this slideshow. So we have This is retinal pigment epithelium detached from the underlying Brooks membrane, and here we have drusen's, where we have solid deposits between the Brooks membrane and the retinal pigment epithelium. Here we have hyperreflective subretinal deposits as seen on a ARMD, and here we have a scar formation with no presence of fluid or any inflammatory sign. Here we have a cystoid macular edema as seen on OCT in a case of diabetic or a central retinal vein occlusion, and here we have an inflammatory SRNVM which is causing tissue edema, but at the same time the retinal pigment epithelium is grossly disturbed and elevated with some amount of deposit in the space. So again, coming back to the list of OCT macular terminology, and I hope we can now recall each one of these lesions as visualized in the earlier slides, and we'll be able to make it out when we see the OCTs in future. And these are the sources for further reading, and these are good publications. This is one journal which has very nice information about reading macular OCT as seen in normal patients and macular and retinal diseases. And this is one PDF which you can download. This is from Heidelberg Engineering, which make the HRT, OCT machine and fundus camera. And this PDF is very useful, and they have very nice images depicting OCT changes in disease and the normal OCT. So this finishes this session. Enjoy and learn. Thanks.